Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera, salam sehat buat kita semua. Good morning, ladies and gentlemen, my fellow colleague in Indonesia and surrounding. And good evening to our distinguished speakers, Professor Dr. Howard M. Sandler in the United States, far away there. Welcome to the first IROS webinar in 2023, and it's the last webinar done by the IROS Cabinet in this period. Since that next week we will have a very special event in IROS. IROS is Indonesian Radiation Oncology Society. We will have next week the IROS conference, and there will be a new president election, and of course there will be a new structure and a new cabinet of IROS. So to Professor Sandler, for your information, IROS is established in 2010, and nowadays we have 153 members, which the product of the new radiation oncologists was around 12 to 15 yearly, and we always follow and balance the number of radiation oncologists with the number of radiotherapy centers, services that we have. Right now we have 53 centers in 85 machines. Of course, it is not enough for 270 million population that we have. And we have a that's the reason why we have a multinational initiated, the multinational study granted by the IEA RCARO, office in Korea, to know the gap using our own radiotherapy utilization rate. And the study followed by the most radiotherapy center in our country. So we know how is the gap right now. This project of a gap study midterm meeting will be held hopefully in Bali this year. That's also the information for all of us, all the centers, because most of the centers follow this study. And thanks God, now we got a special attention or priority from our government. And nowadays we hand in hand with our government as well as with our private sector to close that gap and our need to close the gap of our need for radiotherapy services. And at the end of 2025, it is already planned and it is already started. Hopefully we will have 95 centers. You can imagine it is increased around 40 centers and 154 machines. It's around increased 60 machines with around 175 radiation oncologists. That's us. In this webinar, is a monthly webinar started when we have a COVID pandemic. And I'd like also to thanks, because this is the last webinar for our period, I would like to thanks to our the IRORA, our residents associations, for your big continuously work to run this monthly webinar under the supervision of Dr. Henry and Dr. Maya. Thanks a lot. So we are very hopeful that this year we will be able to see each other after the pandemic time, again in person many times, and looking forward to many impactful events. Since that after we will have our annual conference next week in Jakarta, because the last time was 2018 in Bali. It is due to the pandemic, so it is we can do it just this year. And in June, we will also host the ASTRO card evidence-based radiation oncology. So I really hope to have everyone full support for IROS team and events. And Dr. Sandler, I'm really looking forward to welcome you also in person in Indonesia too this year. As we know, that Dr. Sandler is currently the president-elect of ASTRO, the largest radiation oncology professional society globally. So thank you very much to your time to be with us today. And this is a very special occasion. Hope our society is also can follow the ASTRO, and we'll also have a new, not only the president, but also the president-elect exactly like you in ASTRO. As we know that prostate cancer number of cases is increasing right now, I'm sure that one of the reasons is prolonging life expectancy of men in our country. And so it is very important to hear from Professor Sandler. One aspect in the important treatment of prostate cancer is radiotherapy. And also welcome to our panelists from Indonesia. Professor Reni Umbas is the most senior uro-oncologist in our countries. And Dr. Agung even is the young guys, but full of expertise. And Dr. Julijamnasi is our radiotherapy from north of Sumatra, one of the big, most west island in Indonesia. Thank you very much for being here with us and join us at this special webinar. Before we begin, let's take a group photo, Maya.
Yes, please. We will take a group photo in the panel room first. Okay. Dr. Dika, would you please guide us to the photo taking?
Dr. Ari, Dr. Henry, can you turn on the camera?
Okay, dear respected Prof and Doctor, my name is Dika from Radiation Oncology resident from Indonesia. First, I would like to thank you for joining our webinar today. Now I will assist you in taking our group photos. The picture will be taken twice, so kindly turn on your camera and please hold still for a brief second so we can get a clearer picture. Okay, 1, 2, 3, smile. Once more, 1, 2, 3, smile. Okay, back to you, Dr. Maya, Prof. Tati.
Okay, thank you. So allowed me to continue leading this webinar because this is the last webinar, as I mentioned several times. I would like to remind everyone watching that you can ask at any time during our session. Please type at the QA box, and we will read your question during the discussion session, or you can also raise your hand to talk at the session. Now, let me again introduce our keynote speakers for today, Dr. Howard Sandler. Is the chair of radiation oncology at Cedars-Sinai Hospital, Los Angeles. He also holds the Ronald Blum Family Chair in Cancer Therapeutics. As we mentioned before, he is currently the president-elect of ASTRO. ASTRO is American Society of Therapeutic Radiation Oncology, the largest radiation oncology professional society in the world. He held an important leadership position within the Radiotherapy Oncology Group, or RTOG, or NRG Oncology, and helped direct or lead practice-changing clinical trials. Dr. Sandler's research interests include prostate and genitourinary tumors, among other subjects, and he has written more than 300 articles on prostate cancer and radiation therapy in peer-reviewed publications such as in GNCI, Journal of Clinical Oncology, Lancet Oncology, JAMA Oncology, JAMA, and the New England Journal of Medicine. He will talk today about the prostate cancer radiotherapy in the era of personalized medicine. As we all know, the advance in cancer medicine, included radiation oncology, is moving very fast. The same applies to prostate cancer therapy. So we are really excited to hear the latest update from Dr. Sandler. I hope that everyone will make use this precious opportunity to learn from our speakers and panelists and share our thought also in the discussion session. Let's work together to improve our patient care. And with that, I invite Dr. Sandler to please start your talk.
Thank you so much for that wonderful introduction. It's a pleasure to be here. Virtually speaking to almost 200 people Saturday morning where you are, and Friday evening here in Los Angeles. I was invited to speak about prostate cancer and to put a focus on radiotherapy and personalization. So I'll try to talk about prostate cancer, give some background. I can't help it, but a lot of the talk will be about radiotherapy, but I think there'll be plenty for non-radiation oncologists to appreciate as well. So let me share my screen and we can begin. How do things look? Good? So I put my email on here. Feel free to reach out anytime if you have any questions. So as mentioned, I am the president-elect of ASTRO, I think the largest radiation oncology society in the world. And so I just have a couple of slides about ASTRO. Being president-elect, I couldn't help myself. I hope to see some of you this fall in October at the annual ASTRO meeting, which will be in San Diego, California. So on the west coast of the US, make it a little bit easier for people from Indonesia and surrounding countries to make it to California. This picture I like. It's the first meeting of the organization that eventually became ASTRO. I don't know the names of the people who signed, except for a couple. And here's Gilbert Fletcher, who was one of the really founding radiation oncologists and spent most of his career at MD Anderson. I still have one of his textbooks in my office. So the society started as a club, a small mini society, and Juan Delgado, a famous radiation oncologist, came up with our original logo with a crab being as a symbol of cancer surrounded by nuclear orbitals. ASTRO today is over 10,000 members. As I was discussing earlier, in the United States, we have between 4,000 and 5,000 radiation oncologists. We left our partners in radiology formally in 1998 and became a fully true independent society, which I think is important for us in radiation oncology. We're organized in terms of councils, and each of these councils has board membership, including, and recently and importantly, 2 board members representing diversity, equity, and inclusion, an important topic in the US. So let's talk about prostate cancer. And I can't help but being semi-United States focused. So some of the studies are highlighting things that are more relevant to the US than perhaps in Indonesia. And I apologize, I should know more about prostate cancer's impact on such a large country as Indonesia. But in the US, if we were talking about who would be at risk for getting prostate cancer, certainly we all know that it's an age-related illness and that the risk of prostate cancer goes up strongly as men age. It's also related to ethnic background. And in the US, men of African descent are at increased risk for getting prostate cancer for reasons that I think are a little unclear to me. In general, the risk could be considered to be genetically related, or could be environmental, or there potentially could be some interaction between genes and environment. I think that probably both genes and environment are related, and it's potentially partially diet related, and the interaction between diet and race might be a factor in why African-American men in the US are more likely to get prostate cancer. However, men who present with similar stages, their prognosis is the same whether their original ethnicity is white or black. Family history is important. All genetic predispositions for prostate cancer probably have not been found, and I'll talk a little bit more about that in a second. But of course, if environment or diet is an issue, those factors also tend to run in families, so it's sometimes hard to separate genomic influence from a familial/environmental influence. But family history is a very strong factor, and if a first-degree relative, such as father, brother, or son, has prostate cancer, a man is at much higher risk of getting prostate cancer. As I mentioned, diet is a risk factor. we always quote this study, and I'm not an epidemiologist, so forgive me if it has some flaws, but historically, men in Japan have a low incidence of prostate cancer. But if Japanese individuals emigrate to Hawaii in the US, their children have a higher incidence of prostate cancer. So their genetics should not have changed. We're talking about first generation after immigration. So it seems like a strong argument that perhaps a Western diet versus a Japanese diet might predispose one to getting prostate cancer. And I think there's probably some truth to that. If you served as a US soldier in Vietnam, where Agent Orange was used as a defoliation device, a defoliation strategy, there's felt to be an increased risk of prostate cancer from a carcinogenic effect. Again, I'm not sure how good that data is, but I know that it's recognized by the US veterans hospital system. And so veterans who served in Vietnam are considered to have, if they have prostate cancer, to have it at least partially contributed by their service in Vietnam. So what about genetics? So there is an increased risk of prostate cancer with mutations in some of the genes that are listed here, including the BRCA genes, mismatch repair genes, HOXP13, ATM, TRK2, PALB2. And about 15% of metastatic prostate cancer patients have germline mutations in one of these genes. It's actually recommended by NCCN that patients with metastatic prostate cancer have germline screening to detect these mutations if they exist. Now, most of these mutations don't impact me as a physician taking care of an individual patient. If they have cancer due to a HOXP13 mutation that was detected on germline assessment, I don't think his options are any different. But I do think that BRCA2 does have an impact on my decision-making for a subset of prostate cancer patients. So I was part of a large group of individuals who met in Philadelphia in 2017 to kind of review the evidence for inherited risk of prostate cancer. And some of the genes on the previous slide were identified as being important for testing if there's a family history. But it's felt, and the evidence isn't that strong, but it is considered that prostate cancer patients who have a BRCA2 mutation have cancers that have a worse prognosis. And so in this one study from 2014 of men who had screening detected, i.e. PSA detected PSA detected prostate cancer in Canada, of 4,000 men who were screened, some had prostate cancer. They were all tested for BRCA2 mutations, and the survival was better if they did not have a BRCA2 mutation, and 12-year survival was worse with a BRCA2 mutation. So in my own practice, if I see a patient with low risk or favorable intermediate risk prostate cancer with Gleason 3+4, I'm likely to not recommend active surveillance if they have a BRCA2 mutation because of its BRCA2 mutation carriers have cancers that are worse than expected. Just in way of background, if this comes up so often, the anatomical location of where prostate cancer occurs, I thought I would just, in 1 or 2 slides go over this. Of course, most prostate cancers occur in the peripheral zone, but not all do. And the transition zone harbors some cancers. These cancers are often missed on routine transrectal biopsies because the cancer is not palpable, and transrectal ultrasound biopsies usually biopsy the peripheral zone only without a strategy for anterior biopsies. And it's very easy, I think, and very common to identify peripheral zone lesions on T2-weighted MRI. And so in the US, at least in my area of Los Angeles, I don't know if it's true generally, but in my area, prior to prostate biopsy, patients get MRs. And that offers, I think, many benefits, including MR-guided biopsies, where both the peripheral zone and any lesions in the central gland in the transition zone can also be targeted. Plus, if the patient is a candidate for surgery, then surgical management can be tailored to any extracapsular extension identified on MRI. And finally, although I won't talk about this too much today, other than mention it briefly later on, radiation oncologists are doing micro boosts if the patient is getting primary radiation of MRI-defined abnormalities. And so there's lots of value in MR in the diagnosis and management of men with prostate cancer. Switching for a tiny bit to PSA, any of us who are heavily involved in prostate cancer could talk about PSA for hours, I think. Fortunately for you all, I won't talk about it for more than a couple of minutes, but it's such an important marker and really very helpful. In the US, 75% of men over 50 have had at least one PSA test. So essentially, PSA screening is ubiquitous. It's a product of the glandular epithelium of the prostate and is increased in men with cancer. And the way I think of it is, and I don't know whether this is right or wrong, but it seems to make sense to me. The prostate is a gland-forming organ. The glands, normal glands, are all connected to ducts, and the secretory products of the prostate cancer go through the ducts and eventually exit the prostate. If you have cancer, you still have glands that are formed, but they're dead-end glands. They don't go anywhere. They're not connected to the ductal tree, at least in part. And so the secretory products, since they're not connected and the contents have nowhere to go, they kind of leak through the epithelial lining of the cancer duct into circulation, leading to an increase in PSA. So it's not a perfect screening test. You know that it's got modest sensitivity and specificity. So cancers will be missed by PSA screening, and some people will have falsely or non-cancerous elevations in PSA that can lead to potentially harmful workups. A prostate biopsy has a risk of sepsis and can be harmful to individuals. It can lead to sepsis. So it's not a perfect test, and it can be elevated through non-cancerous things like prostatitis or ejaculation. So talking a little bit about radiation, I can't talk about today's radiation without giving some historical perspective. And being, an old guy, I have this historical perspective of radiation for prostate cancer, including moving from 2D simple radiation to 3D to current IMRT VMET. For those of you who were hoping to get a detailed lecture on prostate brachytherapy or prostate stereotactic body radiotherapy, you'll be disappointed. There's only so much time. And so radiotherapy discussion today will be mostly on intact prostate with IMRT. So a series of trials in the 1990s and 2000s validated improved outcomes with the use of dose-escalated radiotherapy. There was a time when all radiotherapy for prostate cancer was less than 70 gray for an intact prostate, whereas now the equivalent of 78 or 80 gray is routinely used. And since I'm the speaker and I get to pick out the slides, I'll show this paper from 1992 reporting on a dose escalation trial that I ran back in the 1980s when I was at the University of Michigan. And I believe this publication in the European Green Journal was the first report of dose escalation for prostate cancer. Here's just a few of the dose escalation studies, an MD Anderson study, Dutch, a Jatug study, MRC, RT01. You can see in the middle column what the doses were. All the doses were about 8 to 10 gray difference. And in the column just to the right, the percent benefit in PSA control was all about 20% for a 10 gray increase. So 20% roughly for a 10 gray increase. So I kind of mentally think that each additional gray leads to a 2% improvement in biochemical control. This study, I was the senior author on, and Jeff Mahalski at WashU in St. Louis ran it. For me, this was kind of the biggest, best study of dose escalation with, again, what was considered a standard dose back in 2001 when this study was written 20 years ago, to high dose radiation of 79.2 gray. It was for intermediate risk patients, and they were treated with radiation, either 3D or IMRT, without any hormonal therapy. The study was designed to be big enough to observe a survival advantage if one existed. As you can see, there's no difference in survival. And no difference in prostate cancer mortality. Now, one might say that for intermediate risk prostate cancer, 8 years isn't really enough to detect a meaningful difference if one existed. It did lead to a difference in biochemical control, similar to what was shown in all the dose escalation trials. If you give higher doses of radiation, you get fewer biochemical failures. In the supplementary material published in JAMA Oncology, there is this kind of hint that the time to distant metastasis might favor the high dose arm. This is 7 or 8 years. You can see that there's basically no difference in distant mets. So you wouldn't expect to see a survival difference. But if this difference, gets a little bigger, one would expect that to translate into a survival advantage. The p-value was 0.051. And because of that one, I think we were sort of unable to tout this as a real difference. One thing that's interesting though, so there's a small difference in distant mets, but this group here, this 70.2 gray group, they had more salvage therapy. So they had more hormonal therapy than the higher dose group. So this group may have been protected from getting metastasis by having a little bit more salvage therapy. And I guess my point is that, I'm going to go back one slide, that even though there's no survival advantage, no difference observed yet in time to prostate cancer mortality. Biochemical failure is an important clinical endpoint. For those of you who take care of prostate cancer patients, patients find biochemical failure to be distressing. And it leads to more salvage therapies, which can lead to the adverse impact of that salvage therapy. So I don't really have to tell you, but I'm sure you're all doing this anyway, but dose escalation has been well established in the radiation oncology community. And it was able to be done without really significantly increasing morbidity. If you look at late GI side effects, which is the ones that you would be most concerned about, this is the high dose arm, there were 3% grade 3s versus 5% grade 3s. So a small difference in this study. Now, I would say that some of these patients were treated with 3D and that our dose delivery and dose constraint process is certainly better today. And I think if we did the same study today, these numbers would be more favorable. I'm going to talk a little bit about the PROTECT trial, one of radiation oncologist's favorite trials of all time. I can't help myself talking about it because it's a good comparison of radiation and surgery. But sometimes we hear in the US, I don't know if you hear the same in Indonesia, that for high-risk patients, surgery is better than radiation. And I kind of understand why people say that. I think the evidence base for that is relatively weak and biased. But sometimes I share this part of the PROTECT trial. So the PROTECT trial was for intermediate and low-risk patients, but some patients who were being screened for the PROTECT trial, which I'll talk about in a minute, had high-risk disease, too high risk for the study. And there were 500 of them almost, with a median PSA of 33, 23% had Gleason 8 to 10, and 72% had clinical T3. So these are relatively bad patients. They couldn't be randomized on the PROTECT trial. So, but they were followed, and an analysis was done to see how radiation patients did versus surgery patients. And some of these patients, therapy was not specified for these patients. It was up to the treating physician and the patient to decide. So some had surgery, some had radiation, and some had ADT without primary treatment. And in the UK at that time, most of these high-risk patients were treated with radiotherapy, but they were followed out as far as close to 15 years, and no improvement in prostate cancer-specific survival with prostatectomy. So I think this is at least some evidence that for these high-risk patients, we can still be confident that radiotherapy is adequate treatment, and that surgery is not mandatory, although it is clearly an option. So let's talk about the PROTECT trial. Such a good study. It was so good that the New England Journal of Medicine, our best medical journal, had 2 back-to-back articles, one looking at outcomes and one looking at cancer outcomes and one looking at patient-reported quality of life. So they accomplished accrual by having dedicated nurses who were paid for by the study so that the physicians could exit from the discussion. If I was talking to a patient, I would have my bias. If a urologist was talking to a patient, he or she would have their bias. And so the nurses who were hired by the study were able to talk about the trial with patients and were able to get informed consent. The primary endpoint was prostate cancer specific mortality at a median of 10 years of follow-up. This is who the patients were on this study. The mean age at randomization was 62. It's a little bit younger than most radiation patient studies, but these were screen detected patients, so it was early detection. A median PSA was about 5. These are pretty favorable patients, mostly low-risk patients. And they were randomized to surgery, radiation, or active monitoring. And active monitoring was, at that time, relatively not very intense surveillance. And given the baseline Gleason, PSA, et cetera, characteristics, there is no difference observed in prostate cancer specific survival at 10 years, which was the study primary endpoint. Interestingly, the monitoring group, despite being monitored, had more disease progression, as shown in panel B, where the green line is the active monitoring group. No, that's worse. And I think one could say that maybe monitoring shouldn't be done, or maybe monitoring as done in this study shouldn't be done. But it's a little bit disturbing. But there is no difference in progression at 10 years between radiation or surgery. Now, the progression in that green line it's important to at least understand what that is. So the protocol defined disease progression as death due to prostate cancer or death due to treatment. Evidence of metastatic disease would be progression. If somebody was placed on long-term androgen deprivation therapy, that's a little subjective, but was also viewed as evidence for disease progression. Clinical T3 or T4 disease, because all the patients had T1 or T2 disease. So if they had local progression to clinical T3 or T4, or if they had, other evidence of advanced disease like ureteric obstruction. So this shows that the monitoring patients had a fair amount of progression compared to radiotherapy or surgery, which was tied. The second most common form of progression was progression to T3 or T4 disease and long-term androgen deprivation therapy. Monitoring had twice as many metastatic events as radiotherapy or surgery. And this quality of life stuff is very informative, I think, in discussing with patients when they're trying to decide between radiation and surgery. In the US, many of my patients see more than one urologist, more than one radiation doctor to get multiple opinions. And often their final decision is based on their own perception of the adverse impact of either radiation or surgery. Looking at mostly the radiation and the surgery arms, that's gold and red, not blue. The active monitoring quality of life data is complicated because some of those people crossed over into radiation or surgery. So if we leave the blue curve out and just look at the gold and the red, you can see that there's no difference in sort of global quality of life. There is a difference in terms of bowel quality of life. So radiation patients do have some episodes of bloody stools. It's a non-zero. It's a highly significant worsening in GI function. But if you look at how much they're bothered by it during and immediately after the radiation, there's some bother, and there's a little bit of bother. I consider these differences to be real, but relatively modest. Now, if GI toxicity is something that people are worried about, then one might consider modifying that with a SP.or product. That's an absorbable gel that gets placed between the rectum and the prostate to reduce the rectal exposure to the external beam radiation. And this a DVH analysis shows that, in fact, the SP.or leads to lower doses to the rectum. There was no extraprostatic extension allowed. Patients were low and intermediate risk only on this study in this 2017 publication. And it showed that there were, fewer toxic episodes. For example, grade 2 rectal toxicity was worse in the control arm than it was in the SP.or arm, where they had 0 grade 2 events. But this is only 3 patients out of 72. So it's not a 0 number, and each of these is a real human with a real event, but it's relatively modest grade 2 or greater rectal toxicity. So one might argue that this cumulative risk in the control arm is so low that SP.or isn't necessary. I consider it not mandatory, and I describe it as an option to my patients. This group of people in 2021 published this commentary in Lancet Oncology saying, not so fast with SP.or. Think about the risk as well as the benefit. And what they did was they looked at toxicity events that were reported to a governmental database looking for toxicity. And so what they were saying is that this is not a risk-free procedure, and is it always necessary to do SP.or if your goal is to reduce toxicity when some patients will have increased toxicity? Nevertheless, it's a product that's used widely in the US more than 22,000 times in 2018. Back to the PROTECT trial. Sometimes I discuss this with patients talking about a problem with erectile dysfunction. All the radiation patients had short-term hormonal therapy. So this gold curve is the radiation curve. Men reporting a problem goes from about 15% before treatment to about 50% after treatment with some recovery. After surgery without ADT, about 2/3 report erectile dysfunction with some improvement over time. This is a difference that's real. I think radiation's a little better than surgery at protecting erectile dysfunction, but both modalities carry a risk of erectile dysfunction, and no patient should go in to have definitive treatment for prostate cancer unless they're willing to accept a risk of erectile dysfunction that's around this big. As far as urinary side effects, this seems to be a good summary statistic. Do you wear pads? Yes, I wear 1 or more pads per day. At time 0, no one uses pads, hardly anyone. After surgery, it goes up to about 40% with some improvement by 2 years. With radiation, it's very close to 0. And I usually tell people that there's no risk of urinary incontinence after radiotherapy. I'll talk a little bit about hormone therapy because at the end, when I get into personalization, I'll be dwelling on the hormonal therapy a little bit. As someone who is heavily involved in RTOG, this is an important trial of about 2,000 men who had mostly low and intermediate risk disease. They were treated to standard dose at that time for these patients in 1994, which was 66.6 gray, and were randomized to receive short-term hormone therapy with flutamide and leuprolide monthly or goserelin monthly for 4 months. And it showed that, and I'm not showing all the data, but for the intermediate risk patients, it showed there was a disease-specific mortality benefit. So at about 10 years, about 3% risk of mortality from prostate cancer. At about 10 years, a little over 10% with radiotherapy alone. So this difference is close to 10%. which I think is meaningful, 21 deaths versus 52 deaths out of 500 patients. I sometimes show patients this curve. Some patients say, I don't want any of that hormone therapy. I've read about it on the internet. It's really bad. And I'll show them this and I'll say, dying of cancer is also bad. And if you take the hormonal therapy, your risk of dying of prostate cancer is less than if you don't. Ultimately, people are empowered to make their own decision. But for unfavorable intermediate risk patients, I usually recommend it. And I did the secondary analysis with some colleagues of mine, looking at the favorable versus unfavorable subsets in that large 9408 study. And if you had favorable intermediate risk, there was no benefit. If you had unfavorable intermediate risk patients, there was a distant metastasis advantage. So for me, this kind of sealed that I would do radiotherapy plus hormonal therapy for unfavorable intermediate risk. And it also shows that there was a survival advantage. If you accept that short-term hormone therapy is useful, traditionally in the RTOG studies, we did it neoadjuvantly and concurrently. But others have looked at when hormone therapy should be given. And this study suggests, this study suggests that when you compare neoadjuvant to concurrent and adjuvant, that in some patients, there's an advantage by withholding neoadjuvant and delivering concurrent and adjuvant. So if you're doing, and this is complex, if you're doing prostate-only radiation, then there's an advantage to do concurrent and neoadjuvant, concurrent and adjuvant for all of these important endpoints. However, if you're doing whole pelvis radiotherapy, which is what I do for high-risk patients, then it doesn't really matter. And so I continue to use neoadjuvant if I'm doing whole pelvic, and I use concurrent and adjuvant if I'm doing prostate only, as I would be for intermediate risk patients. I'll skip this. I'll talk briefly about the BOLA study, because I think it kind of frames the duration of hormone therapy question nicely. And I just call it BOLA 1, but this is the New England Journal of Medicine landmark study comparing 0 to 36 months of ADT for high-risk patients. These are, late 1980s, early 1990s high risk. So these are high PSA, grossly abnormal digital rectal exam type patients. And they got 70 gray using sort of, I just put this on here because I think it's funny how we used to do radiation therapy. But the study showed a tremendous benefit to 36 months of hormone therapy. They saw no difference in cardiovascular mortality. So in the cancer world, a survival advantage that's this big really means something. And this trial fully established long-term hormone therapy as standard of care for high-risk patients. I'll skip that. But then, as all people who give lots of hormone therapy would do, they said, 36 months is a lot. Maybe we can get into a benefit with less. So they tried to do a 6-month course of hormone therapy for high-risk patients using a non-inferiority design published in the New England Journal. And this showed, if we look at deaths from prostate cancer, short-term 6 months, long-term 36 months. So this is deaths from prostate cancer if you have 36 months of hormone therapy. And this is deaths from prostate cancer if you have only 6 months. So the short-term hormone therapy was not non-inferior. It was inferior. There were more people dying of prostate cancer with short-term. So they were unable to conclude that 6 months is adequate. And then in Quebec, Canada, an 18-month versus 36-month trial was reported relatively recently for high-risk patients, showing that 18 months is the same as 36 months for overall survival and prostate cancer specific survival. Now, it does show that there's more biochemical failures if you use 18 months compared to 36 months. But because these curves are identical out past 10 years for prostate cancer specific mortality, in the US today, I think it would be considered standard to do 18 to 24 months of hormonal therapy for men with high-risk prostate cancer. So in summary, for low risk and favorable intermediate risk, no hormone therapy. For unfavorable intermediate, short-term hormone therapy, often given concurrent and adjuvantly. For high risk, 18 to 24 months. And there's a subset, I think, of favorable high-risk patients where I occasionally will consider short-term ADT. For example, a patient who's got a PSA of 8, T1C, Gleason 8 with a single core of 4+4. That person's pretty close to having intermediate risk disease, and sometimes I won't give them long-term hormone therapy. I won't go into these controversies very much, but dose escalation beyond external beam radiotherapy with either brachytherapy or with a micro boost, I think is very promising. I've started to do plain micro boosts on selected patients. The role of nodal radiation is not fully established. I think this clinical trial published in Lancet last year suggests a benefit. This trial is still awaiting data, but I'm encouraged overall that nodal treatment should be used in patients at high risk for harboring nodal disease. And then I mentioned briefly the adjuvant versus neoadjuvant controversy. So let's talk about tumor genomics, a tool for personalization, perhaps. So this is not germline genomics, this is tumor genomics. And my simplistic view is that all of us who care for prostate cancer patients have used NCCN risk groups with great effect. Very low risk, intermediate, high risk, very high. But we recognize, all of us recognize that within each NCCN risk group, there's heterogeneity. So if you take the unfavorable intermediate risk patients, it could be 4+3 with 1 core positive, or 4+3 with 15 of 16 cores positive for cancer. So there is this heterogeneity. Even if all of the clinical factors are the same, the patients might have a different prognosis. And I think we get a little bit more prognostic information by doing tumor genomic panels or genomic classifiers so that we can distribute prognosis within risk groups. So this is one example of trying to do that. Dan Spratt, who's a prolific prostate cancer investigator, used this approach. He took NCCN risk groups and gave them a number of points from 0 to 3. And then he used one of the genomic classifiers, the Decipher test, and broke it into low, intermediate, and high risk. These are sort of company-defined risk categories, and gave 0, 1, and 2 points. And so if you add the points together, you can go from 0, which would be very low, to 5 if you have high Decipher and high risk. And so if you add them together, you get 6 categories, 6 tiers from 0 to 5. And then he kind of broke it up to make it easier into a 3-tier group. And what he showed was that if you use NCCN alone, you don't get a good distribution of prognosis using prostate cancer mortality as an endpoint. What you get is this overlapping of low and favorable intermediate. So, and we treat these patients differently, but their outcome is the same. So this is a little bit, this is not what you would want to see from this kind of tier system. But if you use his system with low, intermediate, and high, you get good separation with almost no prostate cancer mortality at 15 years if you're in this 0 to 1 category. So this is an example of how tumor genomics might lead to personalization of prognosis. So this is a paper that is just not published yet, but the pre-proof is available on the Red Journal website. Looking at genomic classifier study of 3 RTOG studies, all of the patients that were included were high-risk patients, all high risk. But I just showed this spread of the Decipher score, which goes from 0 to 1. You get a 2-digit score. These are all high-risk patients. Notice that you can have high risk with a Decipher of 0.9, and you can have high risk with a Decipher of 0.1. And it's kind of interesting, the distribution. And the genomic classifier score is significantly associated with distant mets, prostate cancer mortality, and overall survival, even though the entire study was high-risk patients. So the genomic score can begin to personalize prognosis even for high-risk patients. And the distant met rates, this is just one part of this pre-proof, 3% for low Decipher, which is 0.45, I think, 10% for 0.45 to 6, and 15% for greater than 6. So that's, I think it's pretty well established that the classifier can be prognostic above and beyond Gleason, PSA, and T-stage. But this study, I think, suggests that it can also be predictive regarding the use of hormonal therapy. So I'm going to use this study published in 2021 that I was, participated in from the RTOG 9601 study. So what was 9601? This is an important post-operative study for men who had biochemical relapse after surgery. And they were randomized to get either placebo or bicalutamide 150 as long-term androgen deprivation therapy. They got 2 years of bicalutamide or placebo. It showed an overall survival advantage to bicalutamide in this salvage radiation patient population. Now, what these authors did in 2021 was showed that the incidence of prostate cancer-specific mortality was correlated with the genomic classifier score. So if you had a poor Decipher, you had a higher risk of METs, and if you had good, it was less. So that's prognostic information. Here's where the predictive part comes in, and I'll kind of walk you through this. So there's 6 graphs here. This is all patients, and this is early salvage patients, those who have a relatively low PSA. And these are the patients that we see mostly. So I'm just going to go through these bars here. Early salvage, 12-year distant mets, prostate cancer mortality, and overall survival. This is the distant met graph, the prostate cancer mortality graph, and the overall survival graph. And what these bars show is each bar represents the difference between the arms at 12 years. So if you have a low genomic classifier, the positive difference, it's greater than 0, means that bicalutamide was better than placebo. So if you have low genomic risk classifier, it's better, but barely better. You could say it's no different. But if you have a bad, oh goodness, sorry, keeps going ahead automatically. If you have a bad Decipher score, intermediate and high, then there's a 10% benefit in distant mets if you get bicalutamide. So this shows that bicalutamide is better by 10%. This shows that bicalutamide is better for prostate cancer mortality, about 8%. And this shows that overall survival is improved with bicalutamide in early salvage patients if you have an intermediate or high Decipher. On the other hand, if you have a low Decipher score, your survival is worse if you get bicalutamide. Your survival is adversely affected. And so the point of this study is that you should maybe withhold hormonal therapy from favorable patients who are getting salvage radiation and only use it for those who have poor genomic classifier tests. In other words, you can use the classifier to predict who's going to benefit from long-term hormone therapy. So now, what's the current state? So in the US, RTOG, NRG is doing 2 studies, one in high risk and one in unfavorable intermediate. So this high risk trial is taking this Decipher test and seeing if we can validate its predictive value. So if you have a favorable Decipher, you get a de-intensified randomization to 24 months of ADT or experimentally only 12 months, which would be a benefit if you don't need the hormone therapy. Or if you have a bad Decipher score and you get as a standard 24 months, or you get escalated with apalutamide. So it's both an intensification and de-intensification. It's personalization of therapy using a genomic classifier. And similarly, for unfavorable intermediate risk, using a different Decipher cutoff of 0.4, there's de-intensification. So if you're unfavorable intermediate with a good Decipher score, you can omit you can be randomized to omit hormonal therapy completely. And if this study shows no difference between these 2 arms, it's a big benefit for future patients. And similarly, if you have a bad Decipher score, you would get escalation beyond ADT with darolutamide. So this is one conclusion slide, and it's a thank you slide for, thank you for inviting me to speak. It's really a pleasure to speak internationally like this. I wish I was in Jakarta with you speaking face to face, but this isn't that bad. I think I've shown that prognosis is well personalized using genomic classifiers with clinical and genomic information together. And our personal biomarkers available to help predict who benefits and who doesn't benefit from various kinds of therapy. And I think demonstrating that we have active clinical trials in this space, I think that we can't say that we're there yet, but we can say that we're getting there. So I'll pause there. Thank you very much. And I'll get out of my
Thank you.
presentation.
Thank you very much, Professor Sandler, for the interesting, deep and wide touch of prostate cancer, as well as to show us different results of studies. And there were a lot of new information that can be used for our daily practice treating prostate cancer. From genomic analysis as the prognostic predictive factor to combined treatment, response of treatment side effect. So we can say that from bench to clinic. So that's the reason why we call it as the personalized treatment in treating prostate cancer. So of course, we have our expert also in our room here. So we continue the session by inviting, first, of course, the most senior is Professor Reni Umbas to give some of your comment. Thank you very much, Professor Sandler, and please, Professor Umbas.
Oh, thank you very much, Prof. Tati. And good evening to you, Professor Sandler. We really enjoy your talk. I believe most of the Indonesian urologists who also attend this webinar, and they will have a more close cooperation with their radio-oncologist counterparts. Because we started in 1995 at the time, with still the old machines where we can give a maximum of 66 gray treatment for prostate cancer. But believe me, we still have 2 patients still alive at this moment. So it's more than 25 years. Thanks to Prof. Tati and her team at the time, where we just used the old, but later on, of course, we moved to the more modern machines. Now, to make it shorter, I think my first questions, actually, I would like to have your opinion. Since, actually, surgery is not popular for prostate cancer in Indonesia. I can say maybe it's only 1/3 of the total patient who have an indication for treatment. But when we do a radical prostatectomy, and then we found a PT3 tumor without lymph nodes. The PSA 1 month after the radical operation is still undetectable. Now, according to the guidelines, that in this situation, you should give an adjuvant radiation therapy. But I can see, or we can see, that in the last maybe 2 or 3 years, there are some centers postpone this early treatment. They rather do a follow-up and give what we call the salvage radiation treatment. And I think in the last 2 or 3 months, we can see an additional treatment combining radiation therapy salvage with the new hormonal agents like abiraterone or other. I would like to have your opinion in this situation, which I believe rather common in Indonesia. Thank you very much.
Sure. Thank you so much, Dr. Umbas. It's a great question, and I'll give an answer, of course. But I could easily have spent 1 hour talking about the role of post-operative radiotherapy, and I elected not to go in that direction. We could talk about prostate cancer for 24 hours. But in terms of the current management of patients who have a traditional indication for post-operative radiation therapy, which would be positive surgical margins or seminal vesicle invasion in my practice. So if a patient has those, currently based on meta-analysis and the Radicals RT trial from the UK, we are withholding immediate adjuvant radiation, but we only do that if there's recognition that early salvage is mandatory. And in the study that showed that omitting or delaying adjuvant radiation, in the study that showed that that was adequate, the PSA threshold for initiating radiation was 0.1. So that's early salvage. If your patient went away and came back a few years later and their PSA was 2.5, they would have missed an opportunity for successful salvage. So early salvage is mandatory, but I am omitting radiation, except I'm omitting immediate radiation, except for 2 situations. 1, if the PSA does not go to 0, and 2, if there's lymph node involvement even if the PSA is 0, I will recommend adjuvant radiation. So that's where I recommend immediate. Now, one last thing, as I said, I could have talked about this at great length. The studies that showed early salvage was equivalent to adjuvant, those studies were strongly weighted towards good prognosis patients. They were highly weighted towards Gleason 7 patients. And so it's hard to know if, for example, your patient was a Gleason 9 patient with seminal vesicle invasion and had an undetectable PSA, maybe that patient would benefit from adjuvant. And so I think it's okay to, in selected patients with a lot of adverse features, multiple surgical margins positive, seminal vesicle invasion, high Gleason, if I see that constellation of factors, I'm probably going to recommend adjuvant, partly because I know that person's going to develop a biochemical relapse pretty soon anyway. So I'm not going to really be delaying their treatment very much. They'll get it now or they'll get it soon.
Okay, thank you. Oh, sorry.
Okay, Professor Umbas, you have maybe another question or another comment?
Yeah, maybe the second, I hope you won't mind to give some comment about this. That it is known that in NCCN that we can give what we call the subgroup of oligometastasis patients. For patients with localized prostate cancer, but they have less than 4 metastasis lesion. And I think in the last maybe 2 to 3 years, we have maybe 4 or 5 patients like this. But of course, I'm not sure about the technology of stereotactic is so well spread around Indonesia or not. So what will be your comment in this situation about treating this oligomets patients with radiotherapy? Thank you.
Yeah, also a very good question. Invite me back. I'll talk for an hour on treatment of oligometastatic prostate cancer too. But I would say that it's, as you could probably tell from my talk, I'm pretty evidence-based in the way that I address clinical questions. I love clinical trials. I love high-quality clinical trials. I would say that in the space of oligometastatic prostate cancer, we're lacking high-quality evidence to base clinical decisions at this point. There's some evidence from smaller trials that suggests that there can be a clinical benefit. For example, in some patients, it's been shown that if you give stereotactic radiotherapy to oligometastatic disease, you can delay the time that patients need hormonal therapy. And so a quick burst of radiation can buy many months of freedom from androgen deprivation. So I think there's recognition that there's value there. Also, in one study from Johns Hopkins, where they did metastasis-directed therapy, in patients whose lesions were all defined by PSMA PET, they did better. They had a better survival. This was a subset analysis, but they did better than patients who did not get stereotactic radiotherapy. So I think there's potentially some value. I think it's early. There's different types, clinical scenarios where oligometastatic disease arises. You maybe discussed someone with de novo metastatic disease at the time of prostate cancer diagnosis. In the US, as of today, we're doing treatment of the primary and metastasis-directed therapy for patients with 1 to 5, maybe 1 to 4 metastatic sites. Because there's pretty good evidence that treating the primary is beneficial. And it's hard to treat the primary and leave the metastatic disease untreated. It's just clinically not satisfying. So if I see a 70-year-old with an aggressive prostate cancer, they might be a candidate for radical prostatectomy or radiation to the primary. And then if they have METs, they'll get MET-directed therapy. I hope that's beneficial. Now, whether the quality of SBRT in Indonesia is great or not, that's up for my Indonesian friends to answer. But there's nothing magical about it. It is radiation, and so I suspect that your radiation colleagues in Indonesia are fully capable of doing MET-directed therapy.
Yeah, thank you
very much, Professor.
Yeah, Professor Sandler. Yeah, Professor Umbas. We have nowadays the number of radiation therapy centers that can use the stereotactic body radiotherapy is increasing. So at least when the center have the cone-beam CT and we have the 4D CT simulator, so they can do the stereotactic body radiotherapy SBRT. For example, of course, in Jakarta and also in middle of Java, east of Java is already spreading. Even in north of Sumatra, we can do the stereotactic body radiotherapy. So it is especially in the center with the new equipment. So because nowadays the product of the new equipment of radiotherapy usually is already completed with the cone-beam CT as well as with the when we want to buy the CT simulator, some of the CT simulator right now is already the 4D CT simulator. Even in our e-catalog, we have so-called the e-catalog for purchasing the equipment, standardized purchasing of equipment in our countries, especially for the government centers. So that's Professor Umbas, some information, but for detail, where place in Indonesia have already a capability to do the SBRT, we can discuss later about the uro-oncologists and radiation oncologists in our countries. Thank you, Professor Sandler.
Yeah,
so
thank you,
Professor Umbas. So next we move to our young ladies, guys, most of expertise, Dr. Agung. Please, Dr. Agung. Dr. Agung is the staff from the radiotherapy department in the Cipto Mangunkusumo Hospital, Faculty of Medicine, University of Indonesia. Please, Dr. Agung.
Thank you, Professor Tati. Good evening, Prof. Sandler. Thank you for your interesting lecture about the recent advancement in the.
I think your sound is a bit bergema. Apa ya?
Echoing.
Oh, echo. Okay.
Yeah.
Wait, Prof.
Maybe I don't know what to do.
Is it okay now, Prof?
Yeah, it is better. Yeah.
Okay, thank you, Prof. Sandler, for your interesting lecture about the recent advancement in prostate cancer therapy, especially in radiotherapy. I would like to comment about your statement that in the United States, an mammary examination is always done before a prostate biopsy. Unfortunately, we are from Indonesia, still have a lot of homework to do because the using of the multi-parametric prostate MR is not widespread due to the limited human resource, both in the radiologist and the radiographer, and also the limited MRI tools, limited only in the provincial capital. I would like to give information about the role of prostate MRI, because I think the MRI itself is already the precision medicine, start of precision medicine in prostate cancer therapy, because it differentiates between the clinical significant prostate cancer and the low-grade prostate cancer. So we can selective to give a therapy focal therapy or image guided therapy in the prostate cancer. So the choice of the therapy is personalized in each patient. And I have a question to you, Prof, about the when do you do the prostate MR therapy after radiation therapy? Because the biochemical recurrence in the PSA is different from the radical prostatectomy. It's can give around about 3 years. So when do you order the prostate MR if you have a suspicious of the recurrence after radiotherapy? Thank you, Prof.
Sure. Yeah, thank you. It was a little hard to hear, a little bit echoey, but I agree with you that prostate MRI is very useful, and it sounds like you said it's not widespread at this point. Multiparametric seems to be important. I'm not a radiologist, but in my experience, the main benefit comes from the diffusion weighted imaging, as well as the T2 weighted picture. And I find that there's little added benefit by giving gadolinium contrast for prostate MRI. And if I was resource constrained, if the availability or the cost of gadolinium was a factor, I would be happy to omit gadolinium as long as I could do diffusion weighted imaging and anatomic imaging. Now, in terms of after radiotherapy to the primary lesion, in my case, I never have biochemical failure. That was a joke. Sadly, I do have some biochemical failures, and I do work them up. But today, and for the past year, really, maybe the past 18 months, my first diagnostic test is a PSMA PET scan, because that basically can identify sources of prostate cancer within the prostate or in the rest of the body. And often recurrences are nodal if the PSA is not too high, or skeletal, and local too as well. So if the PSMA scan, if the PSMA PET is positive only in the prostate and negative elsewhere, then my next test would be a prostate MRI with a referral to urology for an MRI targeted biopsy of the MR defined abnormality. So I do PET MR biopsy to evaluate local recurrence.
Okay, thank you, Prof. Can I ask the question again, Prof? Okay. You say that you choose PSMA PET scan first, and then prostate MRI. In our country, PSMA PET scan is very, very expensive and limited resource. So, how do you choose? You sure this is a systemic recurrence or local recurrence? Because in my knowledge, the local recurrence is best seen from MRI rather than PSMA PET scan. So this is about effectiveness about the modality. Thank you, Prof. How about your opinion?
Yeah, no, I think I'm not sure that's correct. That I think MRI, of course, because of its high resolution, shows anatomical local recurrence better than the PET scan. But I think that, certainly in my experience, the PSMA signal is useful. Now, I'm curious why the PSMA PET scan is expensive in your country. You guys are close to Australia, relatively close to Australia, and the PSMA PET scan is only 10% the cost of a PSMA PET scan in the United States. Australia is much cheaper. So if you could, it would be great if you could import some of that cheap Australian technology to get PSMA PET scans. If you're a prostate cancer doctor, PSMA PET is going to change your life. And so over and over again, my clinical world is flipped around by getting PSMA PET scans. If there's one thing you can do to improve the quality of your prostate cancer management, it's to get cheap access to widespread access to PSMA PET scans. Trust me, your life will be different.
Okay.
Your patients will thank you.
Please, Dr. Agung.
Okay, thank you, Prof. I think thank you for the answer.
Yeah, okay. So thank you very much, Professor Dr. Sandler, because you know that the PET scan in our countries, we have only 4. 1 is in another island, 3 is in Jakarta, and 2 is belongs to the private, and 1 so only 2. 1 is in the island, is belongs to the province, and 1 in Jakarta, it belongs to the government. So 2 belongs to the private. And 1 center that's already extend the use of PET scan to the PSMR is only 1 private center. That's why that's maybe the reason the cost is very high. If I was asking, the question is the cyclotron is still not, the technology of the cyclotron is still not capable to produce the contrast materials for the PSMA. I'm sure that's the 18 what's so called. That's the
F18.
Yeah, and
so there's two PET isotopes that are used. One is F18. So that's 2-hour half-life, but it's cyclotron made. The other is gadolinium. I'm sorry.
Gallium-68. Gallium-68.
Yeah, thank you. Gallium-68, which is made in a generator, so that if you have the generator, you can the half-life of the parent product is pretty long. The generator can sit in the nuclear medicine lab for months, I think, and continuously generate basically free PET isotope.
Yeah, I don't know, but if not, I'm not mistaken, because we are not a nuclear doctors, but if I'm not mistaken, to produce that special contrast for the prostate, they need some adding equipment to put inside the reactor. That's what I heard. That's why it's not yet. Only 1 center can produce can do the PSMA right now, and the price is almost more than $2,000. Maybe it is not expensive for your countries, but for our countries, it is expensive. Yeah,
that's expensive. Yeah, in Australia, it used to be like $500.
Oh yeah, really?
For PSMA PET.
Okay, so now before we move to Dr. Julie, we have some question in the chatting box. I would like to read first. One is from, interesting, it is from the GP, Dr. Joshua Lingo is the GP. So he is asking about what the most recent advance in the field of radiotherapy for prostate cancer, especially in regard to image-guided radiotherapy and intensity-modulated radiotherapy, and how do these contemporary techniques compare to the term of their efficaciousness and adverse effect profile when compared with the conventional method. I think you already, maybe he will be very happy if you can answer just a short about the difference between using the conventional method with the IGRT and IMRT. Versus,
yeah, so So radiotherapy has evolved quite a bit in highly beneficial ways because of better imaging and better targeting. Plus, people like me and the radiation oncologists better and better understand the tolerability of normal tissues outside of the tumor. So we've learned better and better how to target better, how to focus better, and to create radiation plans using IMRT and image-guided radiotherapy, where we with great certainty, we limit the dose to safe levels to adjacent structures like the rectum or the bladder in prostate cancer. Radiotherapy planning and dose delivery has improved tremendously, and it's a result of decades of smart physicists and smart physicians just doing better and better.
Yeah. So that's the answer, Dr. Joshua. So Dr. Joshua is the GP. Thank you, Dr. Sandler. And the next is, the question actually is from our resident, I think. I would like to ask, what is your opinion regarding the use of a SMA PET-CT in prostate cancer management? Can really on it beside PSA, especially in the post-operative setting, because there is some report in some patients, the PSA keep increasing, but the have negative the PSMA.
Yeah, so sorry, could you, I didn't quite get the gist of the question.
So how we can trust the PSMA, because he said that there is some literature mentioned that even the PSA is increasing, but the PSMA is negative.
Yeah, okay, yeah, so PSMA is, as of today, is the best imaging test for prostate cancer. It's highly sensitive and highly specific, but it's not 100% sensitive and it's not 100% specific. So there are false negatives and false positives that occur just like any other tests that we do in medicine. So, so in the US, PSMA became widely available through government approval about a year ago. So in early 2022. And over this past year, I think we've learned a lot about when PSMA signal might be a false positive. I know you were asking more about false negatives, but I think we're still learning about when maybe PSMA is falsely negative as well. Well, for example, I have a patient that I've been consulted on with an elevated postoperative PSA. After prostate cancer surgery, his PSA was about 5. It should be 0. So it was repeated, still 5, so it's real. And he had a PSMA PET scan, it's negative. And that's crazy. I know he has prostate cancer. Why is the PSMA PET negative? Yeah. His urologist, I think, made a good recommendation to get an MRI, which was also negative, and also to consider doing a fluciclovine PET scan. That's another metabolically driven imaging study. It's not as good as PSMA, but if you look at the Venn diagram of PSMA and fluciclovine, most of the time, PSMA finds all the fluciclovine cancers, and even some more the fluciclovine doesn't find. But if you look at the Venn diagram, there's a few patients who are only positive on fluciclovine, but negative on PSMA. So if I was trying to aggressively work up a patient that I was suspicious about who had a negative PSMA scan, I would order a fluciclovine scan, not a scan I would normally use, but might be indicated in that scenario.
Maybe I can give some comment on this question.
Please, Dr. Umbas.
Okay, thank you very much. Yeah, we know that PSMA will give a false negative results. So in Indonesia, the situation currently, I will just go back to our resource limited, that we will not use PSMA PET after radical operation, even if the PSA increase. I rather follow the suggestion by Professor Sandler, early salvage. I think that's the answer in this situation, even without knowing where is the lesion. But if you want to do, for instance, PET PSMA, you have to send the patient all the way to Jakarta or even go to Australia, the cheaper one. But at the end, maybe we still have to give this salvage. That's my belief for this current situation in Indonesia. So just make it easy.
Yeah.
And we want to help the patient.
I'm totally okay with that, because if I see a patient and their PSA after surgery is 0.10, I don't order a PSMA PET scan because I think it's likely to be negative. So I just go ahead with early salvage without scanning. But if the PSA is higher than 0.2, let's say 0.4, 0.6, 1.0, then I'm ordering PSMA because I can.
Yeah, okay. Thank you.
So thank you. It's a good discussion about the topic of PSMA. Now, can we move to the topic of the relapse? There are some questions about this. In case of relapse or progressive after radiotherapy as primary treatment, is it possible to do the re-irradiation when and how, the interval? And another is how about the role of radiotherapy for the low volume metastatic? Is there any benefit? So there are two. One question is about the relapse. Can we do re-irradiation? That's the question. And the second is about the low volume metastatic prostate cancer. Is there any benefit to do the radiotherapy? Please, Dr. Sandler.
Okay, yeah, thank you. So local relapse does happen. I don't think it happens too often, but this scenario arises. And at our tumor board on Monday, we talked about one of my patients who I treated in 2009. So 14 years ago, and now has a local only relapse with a PSA of 3. And so we had a discussion about all the options for management. And one option, I think, is surveillance. So if the PSA is going up slowly, one option would be to just monitor, because all of the treatments are going to have an impact on the quality of life, which is acceptable if there's, the patient needs a, potential life-saving strategy. So what are the best curative therapies for local relapse? I think radical prostatectomy as a salvage treatment is a decent option in an experienced hands. Sadly, the incontinence risk is high, and there's a risk of rectal injury. So it's not a benign procedure, but it, I think, offers kind of satisfying local control. One is concerned about doing radiation on top of radiation because maybe the tumor is radio resistant and that's why it reoccurred. But that said, there's a fair amount of evidence that suggests that brachytherapy can be used for salvage. And so in our practice, we tend to use salvage brachytherapy with HDR. I don't do that, one of my colleagues does, so don't ask me for details, but salvage brachy is what this patient is going to get. I'm not a fan really of focal therapy. It seems like a tumor that's bad enough to reoccur after radiation is unlikely to be successfully managed upon recurrence with focal therapy. So I would think radical prostatectomy and brachytherapy, maybe focal therapy, maybe monitoring depending on the patient's age and other factors. In terms of low volume metastatic disease, was that the other question?
Yes.
So, I mean, I see so many different scenarios like this. So one I already talked about, de novo prostate cancer, newly diagnosed with metastatic disease. I'll treat the primary and SBRT. Another common scenario is I'll treat someone and then they fail biochemically, and on PSMA PET, they have bone-only disease, and I will treat SBRT for that. Another scenario is nodal-only disease, and I don't treat nodes with SBRT. So if a patient has prostate cancer treatment by me and then they relapse superiorly in like the lower para-aortic chain, I'll treat kind of an unblocked nodal area with simultaneous integrated boost to the abnormal nodes, and I'll match that field onto the previous radiation. So I'm not a fan of nodal only SBRT, except in selected situations, but for any skeletal lesion, SBRT, and I usually use a 3-fraction approach. 9 gray times 3 is my most common SBRT fractionation.
Okay. Yeah. Thank you, Professor Sandler. So there are still some questions are not yet answered in the QA box, but I think we have to go back because Dr. Julie is already here, already waiting here to give his comment. Please, Dr. Julie.
Thank you, Prof. and Indonesian Radiation Oncology Society for the kind opportunity. Allow me first to greet Professor Sandler, Prof. Umbas, and Dr. Agung for this robust discussion. So as the life expectancy of our population in mostly developing countries is increasing, I think it is common for us to see increasing prostate cancer cases. And if I may simplify the problem we always have in our centers as a radiation oncologist is how to select the best treatment options for the patients and which modalities is the best to do routine follow-ups, and also what other treatment options is available when the patient is showing progressive disease. So most of my question, I think, has already been discussed with previous question and answer, and also by the talk of Professor Howard. So may I ask Professor Howard, regarding the patient with perineural invasion, we will still suggest to do SPRT, and you know, as we are moving forward to genetic testing, is there any data to compare between germline mutations and also the somatic mutations to decide the dose or the technique we should use for our patients? And how about the hypofractions? You know, I mean the hypofractions we know is beneficial to our patients, but you know, is there any criteria for you to select which kind of patient should go to which kind of machine? Just say, you know, we have a lot of selection of machine, LINAC machine, I mean. So do you have any opinion about this, Professor? Thank you.
Okay, no, thank you. Thank you for the questions. So let me see, usually it's easier for me to go to the last question first.
Okay.
So, you know, I'm not sure what kind of machines you have. In general, I think a good radiation oncologist can treat well with any machine that's capable of IMRT. So if you can do IMRT with 6 MV or 10 MV or 15 MV, and you have the ability to do cone beam CT, then that would be adequate for, I would say, nearly all prostate cancer patients. And then in terms of germline or somatic mutations, I think there's people who are looking for toxicity signatures. For example, some kind of germline signature that might lead to increased radiosensitivity, an increase in toxicity. I think there's even some commercially available products that purport for that, but I haven't been impressed with the data enough to use those tests to define my treatment. So I would say I'm not convinced about that, but it seems like it's a reasonable strategy. For example, if a patient is deciding between surgery and radiation, and it looks like they might have an increased sensitivity to radiation for toxic events, maybe they should get surgery. But I don't know that the data is powerful enough to be confident that that's a good recommendation. So that's your second and your third question. What was your first question again?
Regarding the patients with perineural invasions, will you still suggest the Sp.RT? Yes.
Yeah, so perineural invasion, it's one of those things that's associated with like a worse outcome. But what I've found is that perineural invasion is very common, actually, and it's often depends on the pathologist who's looking at the biopsy, whether they call it or not. And it's so common, really, if you look hard for it, that it would prevent you from doing a lot of what we do if you were going to limit your treatments based on perineural invasion. I wrote one paper a long time ago suggesting that if you do perineural, if you do a radical prostatectomy on patients whose biopsy shows perineural invasion, that their pathology is higher risk than if it was without perineural invasion. So I think there's probably some association. But for me as a radiation oncologist, I try to, through my my PTV margin, try to account for reasonable extraprostatic extension outside the prostate capsule, which is really what perineural invasion is associated with. It's associated with an increased risk for extracapsular extension. But I think I treat that disease with SBRT or with fractionated therapy. So hypofractionated or standard fractionation. So I don't, my bottom line is I don't use perineural invasion to determine what kind of treatment I deliver.
Okay. Is it okay, Dr. Julie? Is there any other question? We have.
Yes, if I may ask one more question, Prof. Taufik.
Yeah.
Just a very simple question. What kind of modalities do you use for routine follow-up? Is it enough to monitor the PSA, velocity, or you will integrate another modalities for that? Thank you.
Yeah. So yeah, PSA is so useful for follow-up. So if a patient I treat gets hormone therapy and radiation, I do PSA every 3 months if I'm giving them leuprolide injections, and I measure their testosterone too, just to make sure that the leuprolide's working. So I'll do a testosterone and a PSA every 3 months. When the hormone therapy stops, I'll continue testing every 6 months, PSA and testosterone, until the testosterone normalizes, and then I stop checking it. And then if they don't get hormonal therapy, then I check the PSA 2 months after radiation, and then every 6 months for 5 years, and then once a year until year 10, and then I stop following them. And that's kind of consistent with NCCN guidelines.
Okay, thank you, Prof.
And NCCN, and this is what I do too, it suggests that if the PSA is fine, there's no reason to do a digital rectal examination.
Okay. Okay, Dr. Julie.
Yes, thank you very much for the information. Thank
So
you.
thank you very much. Because of the time, Professor Dr. Sandler, it's already quite late, must be in there in LA. So it's already time to sleep for you. I can show, I can
Almost.
So as the resume of this webinar, I think the radiotherapy with escalate dose is currently the standard of care for definitive prostate cancer treatment. And side effect of radiotherapy such as bowel and erectile dysfunction is relatively low, especially when we use the advanced radiotherapy technology. And ADT plus radiotherapy is highly recommended for intermediate and favorable and above. And also the role of prophylactic nodal radiotherapy has been established, but recommended in high risk and above. And a genomic, that's important, make it become personalized. Classifier is evolving for prostate cancer, and we will see it to be incorporated into the clinical practice in the future. So what's we call as the from bench to the clinic. So as a conclusion, radiotherapy has a great role of prostate cancer management. More to come in the future, such as localized boost and proton, etc. So I think that's the conclusion, and we would like to, as the IROS, we would like to thanks very much to Professor Sandler and also to all the panelists for the very interesting discussion between the attendants and Professor Sandler, and also among the panelists itself. So thank you very much again, and hope we can see someday, sometime close this year. Maybe we can invite you to come, or I know that your hospital have also a good collaboration with the one private hospital here in Jakarta. So maybe when we will start to do some radiotherapy treatment in that hospital, we can also invite you also to come. So thank you very much to everybody, and have a nice weekend for the friends here in Indonesia or in our region, and have a good sleep for Professor Sandler. Thank you very much.
You're welcome. Thank you. It's my pleasure.
Thank you. Bye-bye.
Thank you.
Thank you, Prof.
Thank you. Thank you, Sailis.
Thank you,
Yeah.
everyone.
Terima kasih.
Thank you, everyone. See you.